Hello, everyone. My name is Devesh Rai. I'm a first-year cardiology fellow at Rochester General Hospital, and I'm a CardioNerds Academy faculty and director for CardioNerds Journal Club. I am pleased to be here with Dr. Chris Anthony, cardiology fellow at Heart and Lung Transplant Unit, St. Vincent Hospital, and Victor Chang Cardiac Research Institute, Sydney, Australia. Dr. Anthony is an accomplished researcher with an interest in the field of cardiac imaging. Thanks for being here with us, Dr. Anthony. And congratulations on your recent proof of concept paper in Circulation regarding the role of cardiac magnetic resonance imaging for rejection surveillance after cardiac transplantation. It is a very interesting study, and reading the manuscript shows the amount of effort gone into conducting this study. The study essentially has two parts: an essential observational studies or validation cohort, which enrolled 33 post-transplant and 33 healthy patients. And this was done in 2014 to 15. So I'll come to my first question. Please share with us how this proof of concept idea initially started, and why is this very important for our patients with heart transplantation?
Thanks very much, Devesh, and thanks for the opportunity to share our research with your listeners. The proof of concept sort of came about when we sort of looked at MRI as a modality that's very, very sensitive and specific at detecting myocardial edema. Now, as you may or may not know, allograft rejection or heart transplant rejection is an immune-mediated process. It's usually a T-cell-mediated process or a humoral antibody-mediated process. And the common pathway, irrespective of the immunological sort of type of rejection, is myocyte edema. So if you've got a highly sensitive and specific method or scheme or modality that can detect edema, the concept or the thought process behind it was, how do we marry cardiac MRI and the different MRI techniques to evaluate edema in the heart with detecting a process like heart transplant rejection, which the endpoint is significant myocardial edema.
It's amazing. So that shows like how cardiac imaging and heart transplant goes, and essentially heart failure, advanced heart failure goes hand in hand to find these patients. So the results was definitely interesting, and you and your group worked on developing a cardiac MRI-based multi-parametric assessment. This multi-parametric assessment included a cardiac MRI specific characteristic and lab values as well. So how did your group came up with the variables used to assess for acute cardiac allograft rejection? And how did this multi-parametric assessment compare to the conventional endomyocardial biopsy?
Yeah, it's a great question. So T1 and T2 mapping, which is a specific MRI-based computer-generated map that allows one to detect fibrosis or scarring and also edema, is well validated across a myriad of myocardial pathologies. So be that scar, fibrosis, or edema. So what we decided to sort of utilize was generalized sequences, for example, a Molly sequence, which is very widely used to generate T1 maps, a general sort of turbo spin echo type sequence to generate T2 maps, and try and compare that directly in our validation phase to the endomyocardial biopsy results for rejection. So in all transplant programs in the first year, what they have is basically a screening period or screening phase in the first 12 months post-transplant, which is the highest incidence of rejection for patients post-transplant. So what we did was we set up the validation phase where we basically randomly selected patients. As you mentioned, there was 33 patients in the control group of transplant recipients, 33 normal controls as well. So we had no issues with regards to establishing normal cutoff points, which is a key concept with regards to coming up with a multiparametric method to assess for elevated values or edema. And we compared that to the gold standard. So this was an imaging compared to histopathological diagnosis type validation study. So based on that, we found that the degree of accuracy for both T1 and T2 was significant. We're reaching close to 85 to 90% sensitivity and specificity to assess for significance, so at least grade 2R rejection in our cohort. And this has basically been reproducible across multiple centers and multiple sort of scanner types across the world. There's been at least 11 studies, and there was a beautiful meta-analysis that was done last year, published in JACC Imaging, that again demonstrated that if using T1 or T2 mapping or even ECV mapping and late gadolinium enhancement, you get very good correlation to biopsies. So I think they had about 276 comparisons, and the sensitivity and specificity for T2 mapping was found to be the most closely related, so about 85 to 90% to the histopathological diagnosis of rejection on biopsies. So this isn't really something that we're sort of picking out of the blue. There's been a good lineage and a good history of validation across the board, across scanners, across centers, and across sequences. And we just were able to utilize our validation study, and we're the first group in the world to actually use the results, use our thresholds that were developed from that validation phase for the detection of rejection, and then compare in a randomized outcomes fashion, one-to-one, a CMR only strategy versus the traditional biopsy only strategy.
Wow, that's just amazing. I'm just like trying to understand like how the timeline went from the starting to the end, and how you guys were able to like enroll patients and do a prospective study comparing CMR to that of the invasive biopsy study, and show that this was in a randomized fashion to show that both are almost equivalent with the 90% accuracy almost. So the results are definitely promising for sure. So, and this has been called by multiple people that this could be considered, that CMR could be considered as a virtual biopsy. So what are the next steps for validation and implementing the results of this study on large scale parameters?
Yeah, absolutely. So I think our study is the key seminal proof of concept study that once you conduct basically a validation phase within your own center, i.e. establishing what your normal control values are for your T1 mapping, T2 mapping sequences, and once you establish what your cutoffs are for actually significant rejection and intermediate phase rejection, you can then safely compare that to a traditional biopsy-only based strategy. The next stage would obviously be a randomized outcome study in a multi-center type setting across scanner types and across vendors, and also across mapping sequences. Now, the challenge here is that obviously there's high variability, just like strain, for example, with echo, with regards to vendors and software, etc. But the key is trying to generate what your norms are based on your specifications, your field strength, your software, etc., and then establishing your thresholds and cutoffs, and then prospectively analyzing outcomes on a one-to-one randomized fashion. So that's the next step where we're going to sort of head towards. Hopefully a multi-center, multi-country sort of registry type setting study, where we establish the normal thresholds for patients across scanner types, establish the pathological thresholds across scanner types, and then conduct a randomized phase across centers.
Wow. So that will be amazing to see a study of this significance of this large scale, to see on a large scale across multi-center, multi-country basis. So thanks for sharing your time and expertise with us, Dr. Anthony. Congratulations once again for this proof of concept study, and I'll look forward to your next study in this area and further more studies.
Oh, fantastic. Thank you very much for the opportunity.
Thank you.